today's webinar is to talk about the randomized controlled trial evidence, the placebo effect, and what is the issue with sham controlled trials. Those are my disclosures, and I'll give you a minute or two to wade through them.
Some of your slides are not advancing, and if you go into the slideshow mode.
Okay, hang on now. That always happens here.
Yeah.
You get a first time it does not work, and now does that work?
Yep.
Yes.
Okay. So here is the hierarchy of evidence, and I won't bore you with all the details of that, but I want to concentrate here on the randomized controlled trials and the RCTs and neuromodulation in particular. We are very familiar with industry-sponsored RCTs, and if I were to quote them all, I probably would fill the screen a little bit more than this, but these are sort of the backbone of our evidence production in SCS, and as I say, they are what has advanced our field to a certain extent. Why is that? Because industry-sponsored RCTs are usually multi-center. The design is usually well thought out. They recruit more patients. There is a huge effort put in the retention of patients. There is the monitoring, the data handling. All of this is usually high quality. And more often than not, as you've seen from my previous study, they produce positive results. They produce positive results to the point that Cochrane has collaboration have looked into this to find out why is it that if you ask the same question and funded this study from industry versus non-industry, you might get two different answers. And when they looked at this, they found that there was a difference between the two, but they couldn't explain why industry-sponsored studies usually lead to a more favorable result. They suggested that there is a certain bias, but that cannot be explained by the standard risk of bias assessment, as you can see. But I suggest to you that industry are getting very good at designing and delivering studies, and that is the case. However, there are a number of notable exceptions in neuromodulation, and when you look at those, you'll find that there is a common thread running between them. This is the study that was comparing spinal cord stimulation and refractory angina for versus what is known as low stimulation therapy. So high stimulation therapy was the group that got a normal stimulator and a good controller. Low stimulation therapy got a device that switched itself on for 1 minute daily and switched itself off. So they could feel paresthesia, but it was felt that this was not enough to give them a therapeutic effect. And here is the results of the study. So what are you looking at here? The white bars are change in time to angina from baseline. The black bars are the change in time in mean total exercise duration from baseline. This is the high stimulation group, so this is your normal SCS, and those are the guys who got a 1 minute stimulation a day. As you can see, both groups improved substantially from baseline, but there was no difference. Another study that also is a sham-controlled study or a placebo-controlled study in this case, the comparison of intrathecal gabapentin to placebo as delivered by pump. And you can see here that various doses of gabapentin when compared to placebo produce no difference whatsoever. This study is quite peculiar in that if you look for the placebo effect in the study, you probably won't find it. This is another example of a sham control study in ONS, and the summary is here in this graph, the active group and the control group, and not a great deal of difference between the two. And that's exactly what the study conclusion is. Finally, this is the Reactivate-B study that is yet to reach publication. And this study gives us an indication of the magnitude of the sham response in neurostimulation in general. You can see that at 4 months, so after 4 months of receiving sham stimulation, 47% of patients remain responders. And when you look at the definition of a responder, which is 30% reduction in back pain with no increase in pain medication, it's quite a hurdle to get through. So as a matter of fact, this study has opened our eyes to the magnitude of the effect. Hence the point of this evening's webinar. And so those are the conclusions. There are a number of sham control studies that have shown unexpected results. And the question we would want an answer to is, does comparing a novel SCS mode to paresthesia stim guarantee that we are talking about two modes that are better than sham? And we'll talk about the design of SCS studies and how this may affect the conclusions. With that, I'll hand you over to our two speakers today. Our speakers are Professor Rick North, Professor of Neurosurgery and Critical Care Medicine and Anesthesiology at Johns Hopkins University. Rick is retired from University of Baltimore, but he is the current president of Institute of Neuromodulation of NANS, president of the Neuromodulation Foundation. He will give the first talk. This will be followed by Dr. Rui Duarte, Health Technology Assessment Lead at the University of Liverpool. We will then, after the two talks, we'll have the opportunity to ask questions. You can post questions at any time, if you like, via the Q&A. If you prefer to ask your questions in person, please raise your hand, and at the end of the webinar, we will unmute you and you can ask your question in person. With that, I'll say thank you and hand you over to Rick North. Rick, the floor is yours.
Thank you, Sam. That very nice introduction. So let me see if I can share the appropriate screen with you all. So is everyone able to see that?
That looks good. You
This
just
is,
need to just
Sam
get the
just
full
told you
screen view.
several things. My next slide, which is my disclosures. Let's see.
Rick, if you get to full screen view, we can see your slides, but we can see them in half the screen.
Okay. So let me see if I can find full screen view. If I go
Rick,
here.
If you put slide presentation mode, Rick, it should automatically bring it.
Just go into slideshow.
Yeah, that should, yeah, there you go.
That's it. Thank you.
Okay, good. Okay, so my disclosure slide makes the additional points and gives the perspective that my involvement with neuromodulation goes all the way back to 1973. And so do my disclosures. So as a university faculty member and researcher and occasional entrepreneur, this is what I've been up to for nearly 50 years now. And most recently, and apropos of our topic, one of the first projects undertaken by ION, the Institute of Neuromodulation, was to collaborate with INS and with IMPACT, which is the organization started by Bob Dworkin, Dennis Turk, and other pain researchers to look at a host of different pain research techniques and treatment modalities. And we did a session 2 years ago in Washington, D.C., devoted to research design considerations for spinal cord stimulation. And if you go to their website, impact.org, there's a session here on meetings that has everybody's slides and transcripts of the entire 2-day session. What you're about to hear from us represents a portion of that. And there have been papers that have come out of this. Dr. Duarte is one of our speakers, and he has these 2 papers as lead author in pain and in neuromodulation. And he's going to follow me as a speaker and explain them. So I thought that this slide would be a useful way to introduce the notion of placebo and sham effects of spinal cord stimulation. And I put it in quotes because my then 3-year-old daughter, of course, did not have a stimulator. When she picked up this stylus on a computer design tablet with paint overlays, paint drawing overlays, and so forth. But she had been complaining of pain in her toe from a splinter. And so I asked her if she could draw it on the tablet. And she succeeded in doing so. And having done so, she announced that her pain was better. So it was clear to me then that we were really onto something, and that perhaps the stimulator was superfluous to some of the benefits that we can see in our patients when we apply high technology treatments to their care. Sam Eldabi showed you a version of this. This is actually an older version where randomized controlled double-blind studies are at the very top of the pyramid. And the emphasis I'm putting here is on double-blind. And what we can do in studies of spinal cord stimulation to try to maintain blinding. We try to maintain it in spite of a host of things that can interfere with it. And at the top of the list is paresthesia, which I would submit is the elephant in the room and has been for several decades. It was just a few years after the first SCS implants were done that Yoshio Sabuchi and Blaine Nashold pointed out the technical requirement, as they saw it, that it was necessary for a patient's areas of pain to be covered completely by the vibratory paresthesia produced by stimulation. And J. Law in the 1980s elaborated on that. Let's see if I have a way to go back. Not that I can see. But the idea is that there is a range of stimulation between perceptual threshold, the amplitude at which the patient first feels paresthesia, and discomfort threshold, the highest level that they are willing to accept. And the basic principle is that the lower in that range you're able to cover the entire topography of pain, the better the job you have done in achieving a technically adequate stimulator. So I picked up on what Jay had done, and starting in the early 1980s, my very first desktop PC benefited from collaboration with colleagues at the Applied Physics Lab at Johns Hopkins to develop an interface from the PC where a patient could interact. So these are pain drawing overlays on a game tablet. And that was the 1986 version, which we hooked up to support 2 different manufacturers' RF devices. And then here's the 1990 version that you saw my daughter helping us develop. So we went on to do a whole series of studies. The computer allowed us to do randomized controlled trials, and in some respects to blind the patient as to what we were doing. And so we published a whole series of papers on technical measures of stimulator performance, but this was all on paresthesia based, sometimes called conventional, as well as tonic stimulation. We continued development of this to the point, and this was now 20 years ago, that we had a device that would literally talk to the patient, lead them through a tutorial, and facilitated doing protocols. And so I think this approach holds some promise for future studies to address some of the problems we'll be talking about. Back in 1986, when we first started using this and got permission from our IRB, we put in the consent form that the patients all signed that we might deliver a waveform that you might not be able to feel. And that was intended to include sham or zero amplitude stimulation. But because paresthesia confounds blinding, we never took advantage of that as we might have. This is one of Dr. Duarte's slides from another presentation, and I think this is worth some elaboration. How do we manage the sensations with paresthesia-based stimulation? We can deliver a short burst that the patient can feel, but that might be therapeutic. That appears to have been the case, or is a possible explanation for one of the angina studies Sam Eldabi presented. Delivering subthreshold current that the patient can't feel might be therapeutic. If we turn the device off altogether, it avoids the risk that stimulation at a low dose might be therapeutic, but it risks unblinding participants. So this is a real potential confounder. Well, the notion that overlap of pain areas by paresthesias is a necessity is no longer operative. Tom Yearwood in 2006 was one of the very first to do that deliberately, hypothesizing that it might be therapeutically useful, and he reported this as a poster at one of our neurosurgery meetings back in '06. So the idea now is that stimulation can be effective. So this is just paging ahead without input from me, but let's see if I can regain control of it. Yeah, okay. So with paresthesia-free stimulation, the range of amplitude that patients are using is now below perceptual threshold. With paresthesia-based, it was up in the yellow highlighted so-called usage range. So paresthesia are no longer a surrogate for pain relief. They're neither necessary nor sufficient. And the new usage range is now down below first perception. Since 2010, we have had a number of new and proprietary waveforms which do not necessarily produce paresthesia. In fact, if they do, especially at some of the higher frequencies, discomfort threshold might equal perceptual threshold, but one generally can stay well below that. And so these various novel waveforms have become very popular, and the host of studies that Sam projected earlier were in many cases comparisons of these waveforms, old and new. There's another rather smaller elephant in the room, and that has to do with postural changes in spinal cord stimulation delivery to the cord. So this figure shows the difference in physical position of the spinal cord as a patient changes from supine to sitting position. And this is a plot of the thresholds in those two positions, showing a ratio of 1.25 between them. So if a patient is sitting or standing, and say you have them below perceptual threshold, but then they lie down on their back, the amplitude will go up by 25% in the average patient, and that might unblind the patient as to whether the stimulator is on or not. So that's another potential confounder. Here are some data that we published as a poster, but have yet to put in a journal, comparing voltage and current sources. And current sources, which are becoming almost universal among IPGs, have an even worse problem. And between 44 and 82% increases occur when those patients change posture. So we're trying to maintain blinding despite other issues. One of them is programming. And this is a slide that I got from Sam Eldabi via a Simon Thompson presentation at our meeting in Washington. And the notion here, of course, is that we should take great trouble to present the treatments that are the alternatives in a randomized controlled trial on an equal footing, so that a patient has no reason to expect that one will necessarily be more effective than the other. But if we're doing this with two different waveforms delivered by two different devices from two different manufacturers, inevitably the two of them and their programming staff will get involved, and then suddenly they are competitive, and we run into this situation. And so this is another slide from Sam that Simon Thompson used to great effect in critiquing a very well-known and widely quoted study where a device delivering a new waveform was reported to be statistically superior to a device delivering a traditional paresthesia-based waveform. There were many reasons to think that equipoise was not observed or achieved. So what might we do about that? This is just jumping back to what we were doing 20 to 40 years ago, and used to great effect to do a number of comparative studies, and that's to automate the routine and run it from a single computer platform. I think that remains possible in this day and age, and in fact, as my daughter's generation comes online and is doing these studies, it might be the only way. And so we can do comparative studies of two different treatments and add sham and placebo and not have this potential mismatch that we get with present technology. Other things that can unblind a patient is that their controller might give it away. If, for example, the amplitude limits are not set carefully, then a patient might be able to establish that they do have active stimulation. There are many other control functions to consider. And for rechargeable IPGs, that's another confounder. A patient might notice that their recharge time is much shorter when they're in the control group and are not getting stimulation. So devices have been reconfigured to discharge the battery deliberately and artificially, or at least to give the appearance thereof, and adding an additional sham, if you will, to the sham group. So as we try to design our studies, we of course want to address patient needs, but we have what my friends in engineering would call an impedance mismatch. And it gets much more complicated than that, because we're trying to design studies that will look to the interests of all of these different interested parties. So that brings me to the end of my remarks on the topic at hand, and this is just the shameless plug I routinely give for the nonprofit Neuromodulation Foundation's Wikistim project, which has been online for 7 years now and has thousands and thousands of references extracted and categorized. So it's a nonprofit website that I invite you to check if you haven't signed up already. It's free. Thank you very much for your attention.
Thank you very much, Rick, for this fantastic overview of the sham studies. And I may add to your plug that I have no hesitation in recommending Wikistim. It is my first go-to place in searching for neuromodulation studies. Our next speaker is Dr. Rui Duarte, who has been working on neuromodulation studies as a sideline, not his main occupation, but he's one of the most prolific authors of neuromodulation papers. Although he is not a clinician, he, I think, knows the field much more than many of us. Thank you, Rui.
Thank you, Sam. I'll just stop the screen sharing and I'll start mine.
Yeah, that's fine. We can see it, okay.
Thank you. And on a meta-analysis that we've carried out, conducted a systematic review, and it was possible to do a meta-analysis of studies that had a sham or a placebo comparator. So these are my disclosures. None of them are related with the current presentation, with current work. Of background, spinal cord stimulation is a recognized treatment option for chronic neuropathic pain. Traditionally, RCTs of SCS have used conventional medical management or usual care as comparator. However, these RCTs, it's not possible to blind patients or clinicians to whether they receive SCS or usual care. And it is a well-known fact that knowing what treatment you are receiving can lead to different treatment effects or large treatment effects. So in a way, the true effect of SCS for people with neuropathic pain can be challenged. However, there are new sensation-free SCS modalities such as burst, high frequency, or high density, which enable RCT design that considers a placebo or sham intervention as comparator. And since these modalities became available, there's been some RCTs that evaluated the effectiveness of SCS for people with neuropathic pain when compared with the placebo or sham arm. So this study follows on the review of methods that we performed and was published in Neuromodulation. So the other review focuses solely and in depth on the methods used in these trials. While this review, we just looked at the effectiveness, and we managed to combine results of different RCTs together to look at the overall effect of SCS when compared with the placebo or sham arm. So, as I said, the aim of this review was to investigate the effectiveness of SCS in reducing pain intensity in patients with neuropathic pain when it was compared with the placebo or sham arm. Because there were several differences in how a sham or placebo arm was tried to be enabled, we made a distinction between sham and placebo. So sham we defined as a control where all study procedures and SCS device behavior were the same. So the only difference there was the stimulation being active or inactive. While a placebo can almost be considered as a quasi-sham. So it's described as sham, but there are differences between the treatment arm and the sham arm. So for example, the SCS device will be inactive, and at least one of the procedures or device behavior will be different. So for example, study procedures will be the same, but there will be no current leak. So the patients will not have to recharge their devices, and therefore will be in a way unblinded and maybe may know what treatment phase they were in, whether in the active treatment or inactive treatment. So very briefly, in terms of the methods that we've used, we searched electronic databases, including Wikistim. We also searched reference lists of included studies and relevant systematic reviews. We only included RCTs reporting on SCS for neuropathic pain that had placebo or sham as a comparator. Because we are aware, based on our review published in Neuromodulation, that most of the studies were crossover trials, we used the revised Cochrane risk of bias tool specific for crossover trials. And for the analysis, we combined the data. So our primary outcome was pain intensity, and combined it in meta-analysis using generic inverse variance. And we also conducted subgroup meta-analysis. So these were based on type of control, whether it was sham, placebo, based on those descriptions or other, and also duration of treatment, as some treatment phases range from 1 to 4 weeks. So we identified 8 crossover RCTs, but we can only include data in the meta-analysis from 6 of the RCTs. So this generated 12 comparisons of an active stimulation to placebo or sham control. 6 of the studies, in 6 of studies, the patients already had SCS for some time, so they were familiar with the intervention, and they knew what effects to expect as well. The patients included their condition. So some of the studies had one specific condition, so FBSS or CRPS in 4 of the studies, and 4 of the other studies included a range of neuropathic pain conditions. And also in terms of the type of stimulation being evaluated, this varied across the studies. So this included paresthesia inducing, subthreshold burst, or high frequency stimulation, all of which you'll be able to see very well in the forest plot. So as I mentioned, we used the risk of bias, the Cochrane risk of bias tool to assess the quality of the studies. As you can see in overall bias, none of the studies was judged to have a low risk of bias. So there are always at least some concerns in studies. The 3 studies that were judged at high risk of bias were all due to the domain deviations from intended interventions. And this concerns the fact that there was possibility of carryover effect between some of treatment phases, or the patients being aware of what intervention they were receiving, either placebo or sham or an active stimulation. That's why those results need to be interpreted a bit carefully. We didn't carry out subgroup meta-analysis based on risk of bias assessment. However, in forest plot, we'll be able to see that the two studies for which we could extract data that were judged at high risk of bias show a larger treatment effect. So these were Shu and Walter. And for Meyer, we could not get data because it only reported zinc median and interquartile range. Okay, so this is a forest plot. In the diamond at the bottom, we can see the overall treatment effect of SCS when compared to placebo across the 12 different comparisons. In the intervention, here we can see that there were many different types of stimulation modalities studied. And in terms of control, these were sham, placebo, or the study by Jetma Klostermans. Although it was registered as a placebo-controlled trial, when reporting, it reported the control arm as being a low amplitude burst. So the patients were still receiving some type of stimulation. In this forest plot, we can see the treatment effect based on grouped by intervention comparator received. So based on our categorization, these were classified as sham or placebo. So diamond at bottom shows again the overall treatment effect. And then we can see the results for sham. So when SCS was compared with sham, there were no statistically significant differences. When it was placebo, there was a larger treatment effect, even larger than the overall treatment effect result. And again, no differences for the study where the control arm was a low amplitude burst. So when we look at the methods to enable sham or placebo, for example, in the Alcasi study, sham was on and discharging, but without electricity transmitted to the lead. So it will be more difficult for the participants to know whether or not they were receiving an active or inactive stimulation. Also in this study, the patients had just been implanted with device, so they were probably less aware of how SCS would work. In the study by Parashow as well, where that was classified as a sham arm, the programming occurred the same way as for high frequency, but the stimulator was switched off, but there was a current leak programmed. So the patients will still have to recharge the device, and therefore they will be unaware whether they were receiving the active stimulation or if the device was just switched off. For placebo, for example, study by Crick, the programming was performed the same way. However, the IPG was switched off immediately and remained switched off during the 2-week test period. The difference to the sham classification is that in this case, there was no current leak programmed. And the authors also report that when the patients were in burst or higher frequencies phases, they had to recharge their device more as well. So in a way, they will know when they were receiving the active phase or not. And studies of Shu and Walter, the device was merely just switched off. So again, it may be a bit easier for the participants to know if they were receiving the active or the inactive arm. And in Jetma Klostermans, the control group was merely a low amplitude burst. So as I said, this was initially registered as a placebo-controlled RCT, but when reporting, as there was some effect for low amplitude bursts for their placebo effect, they classified their control arm as different from placebo. Okay, however, it should be noted that although in our cases study, for example, we can see that there is a significant difference between high frequency or over 5,000 hertz and sham. There were no differences between the other frequencies and sham. And you can see here that it shows that these results were statistically significant. But again, just that the favored stimulation parameter was the higher frequency, so produced better results. In the study by Parashaw, again, although there were no statistically significant effects, the proportion of patients responding to high frequency was larger than those in sham condition as well. And in the study by Chapman-Klustermans, they observed that high burst and low burst were both produced better results than paresthesia stimulation. So in this forest plot, we divided the control groups by the duration of the phases of stimulation phases. So between 1 week, 2, 3, and 4 weeks. Again, we can see diamond at the bottom shows the overall treatment effect. And here you have the results of Shaw and Volter. So the two studies that were judged at higher risk of bias and shows quite a large treatment effect, particularly when compared with the sham arms. So what have we learned? So we learned that SCS does result in a reduction in pain intensity. However, this effect varies across trials and depends on methodological characteristics, particularly how sham or placebo are enabled. We did not identify any studies at the moment compare 10 kilohertz SCS to placebo, and it's important to report accurately how the treatment arms, the procedures for the treatment arms, as even if there's a little difference between the arms, it may be possible for the patients to be unblinded, and that will have an effect. Thank you.
Thank you very much, Rui. If I may start the questions while the attendees think of some questions. A question to you, Rui. You mentioned the duration making a difference. We don't have any parallel group designs in this lineup. Do you think that we would get more information from a parallel group design than a crossover design?
Yes, so in a crossover design, participants act as their own controls. So these tend to be also smaller studies. In a parallel group, so there will be no crossover, at least for the primary endpoint. It would necessarily be a larger study. And if the control group was well designed, then that should be able to give us some more information on the true effect of SCS.
Thank you. I have a question from Dr. Gatterol. Hi, Juan. The question is asked to Dr. Duarte, but I think it probably is to Dr. North. He says, the sham arm in the Alcasi study did have a charge going down the lead, but the lead was placed subcutaneously and assumed to be inert. However, peripheral nerve field stimulation has been used to good effect elsewhere. What are your thoughts on that? And did any of the studies look up objectively measured biomarkers, i.e. proteomics, instead of self-reported pain? That's a question to you, Rui. So if I go to you first, Rick.
Certainly. Well, to the first part of the question, any delivery of charge to other parts of the body has the potential to have a therapeutic effect. And so internally discharging the battery would avoid that. of course, the system could be set up simply to say that it had discharged the battery, to say that it required charging, and to say that it was charging to much the same effect. So I share your concerns about using a subcutaneous lead as a control. It just seems to be asking for trouble.
Thank you.
Yeah, as to biomarkers, there's a relatively small literature on that, but it's been going on for years. And recently, Ricardo Vallejo has done some interesting work in that, looking at the genetics and looking at glial effects as well as neuronal effects. So there's a lot to look forward to.
Thank you. Rui, I suppose none of the studies that you reviewed found or were looking at biomarkers as opposed to self-reported pain.
No, they didn't. So pain was primary outcome in all of the studies, and I don't think any of them looked specifically at other, at biomarkers or other objective measurements.
We have another question from Girish Vajiramani. Good evening, Girish. What is the longest duration of pain relief in any sham group?
So the treatment phases, so they ranged from 1 week to 4 weeks.
Yeah, so 4 weeks in SCS. Are you aware of anything longer than that, Rick?
Well, over many years, there have been anecdotal reports of what one might call inadvertent sham treatment, where it's discovered that a device is broken, and that's why a patient is no longer benefiting from the treatment. But as far as delivering sham or placebo therapy by design over a really prolonged period, I'm not aware of studies that have done that.
I think the angina study that I showed had a 6 months collection of outcomes. However, it did change the primary outcome 3 times throughout the lifetime of the study, so that may have impacted the results. The longest study that we're aware of that has a sham duration is the Reactivate-B study. That's not a spinal cord stimulation study, it's a multifidus stimulation study, and the outcomes were measured at 4 months. Mm-hmm. Another question for you, Rick. One of the studies that Rui showed, they dealt with the issue of the patient controller in a very interesting way. They gave the patient the controller in a sealed envelope, and the patients were allowed to open the envelope in cases of emergency, but otherwise, if they returned to the center with the envelope sealed, then they knew that things were fine. What are your views on that?
Well, I think it is a clever way to address some potential problems. Of course, a magnet is available as a backup controller, but a paper envelope would not suffice to assure that the patient didn't actually use it.
Yeah, yeah, that's my thoughts. Another question that you mentioned, posture and subparesthesia stimulation. One of the difficulties with the paresthesia mode, you can judge the impact of posture on paresthesia, and you can judge whether the postural changes produce paresthesia or not. However, in other subparesthesia modes, we don't know what the impact of posture is on these modes of stimulation. So you may set the mode of stimulation too low, and the whole experiment may be very much subtherapeutic. Is that a concern?
Yes, I think it's a big concern, not only for study design, but also for everyday treatment. And so were I still practicing clinically and doing these things, I would insist on doing paresthesia mapping in all patients with particular attention to what the amplitudes are with conventional frequencies, tonic stimulation, and then using that to calibrate the amplitude adjustment on the new waveform. But very little attention has been paid to that. But it seems to me a very straightforward way to calibrate the dose that you're giving and save a lot of time and potentially saving misunderstanding.
Yes, thank you. I agree. I think the pendulum is swinging away from paresthesia back towards paresthesia. It is quite an interesting movement of the pendulum, but as Rui said, the lack of paresthesia allows us to ask the question about placebo and placebo-controlled trials. Rui, you took us a little bit through the difference between placebo and sham. Would you mind just going through that again, just in case, because it can be quite confusing.
Yeah, so I think this was because of all the differences that we saw in our methods review, and some of the methods used. So the differences, I think, it would enable the patient to know if he was receiving the active stimulation or not, and that's how we came with this distinction. So in what we consider to be a sham arm, so this will almost feel like a true placebo or a true sham, where everything is the same except receiving active or inactive stimulation. While for the, let's say, quasi-sham, there will be differences. At least, for example, so for example, the procedures could even be the same, but then the device behavior, the patient may not need to recharge it. And by not having to recharge it, you will know that he was not receiving the active stimulation.
Thank you.
Yeah. Rui, might another distinction be that whereas sham, it takes the same form as the actual therapy, a placebo could take a different form. So if we did SCS versus oral medication, the oral medication could be a sugar pill or a placebo.
Mm-hmm. Yes, yeah, that could work.
We have an interesting question. What if the IPG was a primary cell? Would that make life easier or more difficult?
Yeah, well, I might have to pass that to Rick because I don't know what a primary cell is.
A non-rechargeable device. Sorry.
Okay, so if device is non-rechargeable, so if the different modes of stimulation can be programmed and the patient can receive active stimulation that does not produce paresthesia, then yes, so that would enable a more easier sham.
Yeah, recharging is unnecessary with a primary cell, and so that just eliminates that opportunity for unblinding.
Yeah, I mean, our experience with using a primary cell in this Pereshu et al. Study is that when we sent the calculation of the current consumption, to the manufacturer's headquarters, they told us that yes, you can use a primary cell, but should you use a primary cell at these settings, the device will last 2 weeks instead of 5 years.
Right.
So yes, you can use a primary cell, but if the frequency goes above a certain level, this is why all these studies are reporting a rechargeable device.
Yeah.
So yes, in answer to your question, your report, you can use the sham for up to 2 weeks, but no longer. Before we close, I'll ask the audience if anybody has any other questions. And I have a comment, just a correction to Dr. Gattrol's question on the Al-Casey study. I don't think this study, there was a lead placed in the subcutaneous tissue. That is the case in the Modulate study, which is still recruiting. But in the study that we talked about here, there were 2 leads placed epidurally. Well, I think we have, I can't see any hands raised. Oh, hang on. We have another question from Simon Thompson. If sham effects are enhanced by high technology, strong expectations of bias of patient and therapist, do you know of a better sham procedure than SCS? I think that's a very interesting question. So I'll read it again. If the sham effects are enhanced by high technology, strong expectations, bias of patients and therapists, do we know of a better sham procedure than SCS? If I may start the answering, I think that applies not just to SCS, but to any implanted technology that is advanced that you are going to apply to a patient, and you can see the impact from the response to sham that we see in the studies.
As long ago as the 80s, I had occasional patients in whom we would escalate, I think that's the right word, from SCS to DBS. So I think it is possible to trump one operation with another.
Yeah, quite. Rui, do you have any views on the impact of a sham procedure versus a sham tablet? Does the literature tell us anything there?
Versus a sham.
I think I saw a study many years ago that asked the question whether a sham procedure was more impactful than a sham tablet. But I can't remember the details, but it did come to the conclusion that a sham procedure was more impactful than a sham tablet, but I cannot recall what was the procedure. Well, I think we've run out of time. We have no more questions, so I'll finish by thanking you both very much for your time, thanking the Neuromodulation Society of the UK and Ireland, Ash and Barani for giving us the platform, and Jenny Nicholas of the British Pain Society for doing all the background work. Hopefully, we'll thank you all very much.
Sam, I just wanted to say thank you again for such a lovely 1 hour on placebo and sham. And I think this is a very interesting area. The question is, do we have to do one?
I suppose from what I presented, if you were a payer and you saw this presentation, would you be asking the question?
No. Hence, I keep saying we should probably collect real-world data. Just enter them all on NNR.
Yeah, by all means. I think real-world data is absolutely helpful, and the National Neuromodulation Registry of the UK, if you're not familiar with that, Rick, it is the platform where we all correct data on our practices. So we've got about, what, 1,500 implants there?
No, it's nearly 2,000 now.
Okay, so it's a question of, we have this data, we should be utilizing it to produce publications. We will get there eventually, I'm sure. But I suppose that doesn't answer the same question of, would you get the same response by not switching the machine on?
Okay.
That would save on battery replacements.
Well, we can look forward to a sham webinar to talk about this.
Well, thank you all very much and have a good evening. Good afternoon to you, Ray.